Good morning, everyone. I am Dr. Divya Singh from the Department of Pediatric and Preventive Dentistry, and I will be taking a lecture on pulpotomy in primary teeth. So, this is my contents. So, as we all know, the retention of pulpily involved deciduous tooth until the time of normal exfoliation is acknowledged to be of great importance. So, pulp therapy is one such measure to prevent extraction. So now, depending upon the extent of pulp involvement, pulp therapy like IPC, DPC, pulpotomy or pulpectomy can be decided. So today we'll be dealing with pulpotomy in detail. So what is the definition of pulpotomy? It is the complete removal of coronal portion of dental pulp followed by the placement of suitable dressing or medicament that would promote healing and preserve the vitality of the tooth. This definition is given by Finn. So it can also be defined as a procedure that involves removing only part of the pulp, eliminating tissue that has inflammatory or degenerative changes and leaving intact the underlying healthy pulp tissue. It can also be defined as a surgical removal of the entire coronal pulp, presumed to be partially or totally inflamed and quite possibly infected, leaving intact the vital radicular pulp within the canal. So the objectives are: the radicular pulp should remain asymptomatic without adverse clinical signs and symptoms such as sensitivity, pain or swelling. There should be no post-operative radiographic evidence of pathological, external or internal root resorption, and there should be no harm to the succedaneous teeth. So the indications for pulpotomy are: if the coronal tissue is amputated and the remaining radicular tissue is judged to be vital without purulence, necrosis or excessive hemorrhage that cannot be controlled by a damp cotton pallet after several minutes. Ideally, the time should be 1 minute. When the caries removal results in pulp exposure in primary tooth with a normal pulp or reversible pulpitis, or after a traumatic pulp exposure. Also, if there is no radiographic signs of infection or pathologic resorption. So basically, there will be history of elicited pain, that is pain provoked by eating or drinking. There will be absence of spontaneous pain or continuous pain. There should always be 2/3 of the root length present. There should be no interradicular bone loss. There should be no abscess or fistula present in relation to that particular tooth. And hemorrhage from the amputation site should be pale red and easy to control. Vital tooth should be there and it should have a healthy periodontium, that is there should be no mobility, and the tooth should be restorable. So in this picture you can see the clinical presentation, and in the radiograph you can see how the enamel dentine which is approaching pulp can be seen without presence of any interradicular bone loss. So the contraindications include a tooth nearing exfoliation or with no bone lying over the permanent tooth crown, if there is persistent toothache, if there is a evidence of periapical or focal pathosis, if the tooth is not restorable, if there is inability to control hemorrhage after coronal pulp amputation. In such cases we will proceed for pulpectomy rather than opting for pulpotomy. Pulp with serious or purulent drainage or presence of sinus or fistula. So coming on to the classification, pulpotomy techniques and agents used can be done in primary and permanent both. In permanent, it is known as Sweck's pulpotomy. In primary, it could be vital pulpotomy or non-vital pulpotomy. In vital pulpotomy, it includes devitalization, preservation, regeneration. So devitalization can be done in single stage as well as in two-stage process. So devitalization in single sitting can be done with the help of formocrosol, electrosurgery or laser. In two stages, it can be done with other formulations like Guy-C strio paste, Acrylics formaldehyde or paraform devitalizing paste. For preservation, we use zinc oxide eugenol, glutaraldehyde and ferric sulfate. Whereas in regeneration, we use calcium hydroxide, bone morphogenic protein, mineral trioxide aggregate, enriched collagen, freezed dried bone. So for devitalization, we will be carrying forward with formocrosol pulpotomy. In this, formocresol has been considered as the gold standard to which all other medicaments are compared for primary tooth pulpotomy. So generally we used formocresol in the ratio of 1:5 dilution, in which 3 parts consist of glycerol, 1 part consists of distilled water, which is equivalent to 120 ml. So one part of formocresol, that is 30 ml, and the diluent which is used as the vehicle is 120 ml, which is glycerol and distilled water. So total 150 ml of formocresol is prepared in the strength of 1:5. So composition, which is known as Buckley's formocresol as well. So the composition of Buckley's formocresol will be cresol, formaldehyde, glycerol and water. So the function of tricresol is it potentiates effect of formalin on protein. Formaldehyde mummifies and fixes the pulp. Glycerol acts as an emulsifier and water acts as a vehicle. So coming on to the procedure. So first of all, local anesthesia and rubber dam isolation is mandatory. So all the caries should be removed. The entire roof of the pulp chamber is cut with a high speed burr and water spray. Now the coronal portion of the pulp is removed with the help of a round burr or a spoon excavator. Now the pulp chamber is washed thoroughly to remove all debris, and hemorrhage is controlled with cotton slightly moistened with saline placed against the pulp stumps, and bleeding should be controlled within 3 minutes. So now cotton pellet is moistened with, after we achieve hemorrhage, so the cotton pellet is now moistened with 1:5 dilution of formocresol, which is known as Buckley's, and it is placed on the amputated pulp site for 4 minutes. So now current studies suggest that the time has been decreased to 1 minute. When the cotton pellet is removed, the pulp stump must appear dark brown or even black, which is a result of fixation. After that, a creamy mix of zinc oxide powder and equal parts of eugenol is placed over the pulp, and the tooth is restored with stainless steel crown restoration. So cotton pellets soaked in full strength formocresol and then squeezed dry could theoretically deliver a dose of 0.1 to 0.5 mg of formocresol to the dental pulp. A cotton pellet soaked in a 1:5 dilution of formocresol, squeezed dried and applied for 5 minutes or less, could deliver 0.02 to 0.1 mg of formocresol. So basically the mechanism of action of formocresol is it acts through the aldehyde group of the formaldehyde, and it forms the bond with both the side group of amino acids of both bacteria and the remaining pulp tissue that prevents tissue autolysis. Therefore, it is both bactericidal as well as devitalizing agents. It kills off and converts the bacteria and the pulp tissue into inert compounds, facilitating the conservation of the deciduous tooth until their physiologic fall. It also inactivates the oxidative enzymes in the pulp tissue adjacent to the amputation site. So effect of formocresol pulp varied depending upon the length of the time the drug was in contact with the tissue. So basically now 1 minute is enough to fix the pulp, but the study shows that after 5 minutes there was a surface fixation blending into the normal tissue apically, and after 3 days it causes calcific degeneration. After 60 days to 1 year, pulp was progressively fixed and the entire pulp becomes fibrous. So the studies have shown formocresol therapy to have a success rate between 70 to 90%. So according to Masler and Mansokhani in 1959, they told that after the formocresol fixation, the various zones of formocresol on pulp appears. First one is zone of fixation. Beneath that, there is zone of diminished cellular activity, and then there is the zone of inflammation, and uske niche there is the vital tissue. This is the radiographic presentation. This is the pre-op radiograph, the first one. The second one is post-operative radiograph immediately, and the third one is 1 month follow-up. So now coming on to the 2-visit devitalizing pulpotomy. It is indicated when there is a sluggish bleeding at the amputation site, and that is difficult to control, if there is a thickening of the periodontal ligament, and if there is a history of pain. So contraindication is non-restorable tooth and tooth with necrotic pulp. It is the contraindication for the entire pulpotomy procedure. So medicament used will be Guy's trio paste, paraform devitalizing paste, or Aslix paraformaldehyde paste. So in first visit, we have to anesthetize and isolate the tooth. We have to excavate the caries, and then we have to de-roof the pulp chamber, and then it will be covered with the devitalizing paste. It will be sealed for 7 to 10 days so that the formaldehyde gas is liberated from the paraformaldehyde and it enters into the coronal and radicular pulp, thereby fixing the tissue. Second visit, after 7 to 10 days, the tooth will be re-entered, temporary filling in the cotton pellet are removed and the chamber is irrigated. Now there will be radicular pulp stumps which will be dark brown or black in color. So now a thick creamy mix of zinc oxide eugenol will be placed over that, followed by stainless steel crown. So again, electrosurgery, it is a single visit devitalization process. It is an atraumatic and a non-pharmacological hemostatic technique of cutting and coagulating soft tissues. So it is defined as the use of specially designed electronic equipment that produces a limited variety of high frequency waveforms for the purpose of cutting or removing soft tissue. So electrosurgery was described as Surgical pulpotomy was described as in primary teeth as time efficient method that is relatively free from the post-operative complications. So mechanism of action of electrosurgery single visit devitalizing technique is this procedure carbonizes and denatures the pulp tissue, produces a layer of coagulative necrosis which acts as a barrier between the lining base material placed and the healthy radicular tissue beneath. Another process is laser, which is used for single visit devitalizing procedure. So it is a non-pharmacological hemostatic technique. Laser creates a superficial zone of coagulation necrosis that remains compatible to the underlying tissues. It also helps in neovascularization, whereas also forms the regenerative tissue, that is osteoblast and fibroblast proliferation. So the procedure includes the pulp is ablated to the level of the canal orifice and the frequency used is 20 Hz in a continuous mode. Laser energy is emitted and delivered through a 0.5 mm diameter optical fiber in contact with the pulp tissue. So the mode is continuous, the frequency is 20 Hz and in a contact mode. Multiple applications can be administered depending upon the hemostasis achieved, and zinc oxide eugenol dressing was then placed directly on the radicular pulp stumps and it will be restored with stainless steel crown. So diode laser is a laser which we frequently use in such procedure. It's a solid active medium laser manufactured from semiconductor crystals using combination of aluminum, indium, gallium and arsenic. These lasers energy is relatively poorly absorbed by the tooth structure so that the soft tissue surgery can be safely performed in close proximity to enamel, dentine and cementum. Now coming on to the preservation pulpotomy. So the first abhi tak whatever we studied was devitalization. Now coming on to the preservation. So preservation helps in the minimum insult to the orifice tissues and maintains the vitality and normal histologic appearance of the entire radicular pulp. So chemical which helps to induce minimal insult to the tissue used are zinc oxide eugenol, glutaraldehyde and ferric sulfate. So zinc oxide eugenol was the first agent to be used for preservation and is currently used as a base material in pulpotomy. Internal resorption is associated with eugenol. So when zinc oxide is used as sub-base, eugenol directly contacts with the vital tissue and causes moderate to severe inflammatory response. Second one is glutaraldehyde pulpotomy. In 1979, Koppel introduced 2% glutaraldehyde, which is also available in 2%, 4% and 8%. So it binds with the protein tissue, which is irreversible in nature. So it has a limited diffusion, excellent antimicrobial agent. It has less pulpal irritation. It has low antigenicity, low toxicity, and elimination of cresol takes place. So the limitation is that it has to be freshly prepared every time required. Concentration used is 4% buffered solution with minimum of 4% 4-minute application. Ferric sulfate is another medicament which is used for regeneration. So it is a non-aldehyde hemostatic compound. It is used as an astringent, less inflammation than formocrosol. It causes root resorption, which is not accelerated. Internal resorption is similar to formocrosol and there is no systemic or local side effects. So the mechanism of action is agglutination of the blood proteins that results from the reaction of blood with ferric and sulfate ions with the acidic pH of the solution. Glutenated proteins form plugs which occlude the capillary orifices and it affects the hemostasis through a chemical reaction with blood. Now coming on to the preservation. Ideal pulpotomy treatment should have the radicular pulp vital in healthy and completely enclosed within odontoblast lined dentine chamber. So in this situation, the tissue would be isolated from noxious restorative materials in the chamber, thus diminishing the chances of internal resorption. So for such results, we use different medicaments. The first one is calcium hydroxide. It was the first agent to be used in pulpotomies that demonstrated any capacity to induce regeneration of dentine. It has a high pH, therefore it wounds the pulp and it permits the intrinsic reparative cascade to begin, adequately controls the pulpal hemorrhage, and it permits good contact between the medicament and the pulpal tissue, which prevents internal resorption post pulpotomy. The second material used is MTA. It has demonstrated the ability to induce hard tissue formation in the pulpal tissue and promote rapid cell growth. It has the property of excellent sealing ability, biocompatibility, bactericidal potential. It forms dentine bridge in cases of pulp capping and pulpotomy, induces proliferation of the pulpal cells. It also causes liquefaction necrosis of the superficial pulp. It causes proliferation, migration, and differentiation of odontoblast, which produces collagen matrix. Calcium and phosphorus is also released. Therefore, it helps in the composition of hydroxyapatite formation. It fills the void and the surface defects, thus creates a bond between MTA and the dentinal wall. Therefore, regeneration and remineralization of hard tissue occurs. The next material used is biodentine. It stimulates tertiary dentine formation and has a positive effect on viable pulp tissue. It has the capacity of tissue regeneration and mineralization. It is biocompatible material. It is strong antibacterial. It has a strong antibacterial action with excellent marginal adaptability. So, Akhtarim et al. In 2016 evaluated clinical and radiographic success of biodentine and they concluded that biodentine as a pulpotomy agent has a high success rate and they should be routinely used in practice for treatment of caries primary molar. The next material is enamel matrix derivative. It is obtained from embryonic enamel as amylogenin. EMD has ability to facilitate the regenerative process. This process mimics normal odontogenesis. It is available in the market as Emdogain gel. So Nakamura et al. Noted that Emdogain induced repair of exposed pulp by fibrodentine matrix formation and subsequent dentinogenesis. Izakazaki et al. In 2003 noted abundant tertiary dentine formation after 8 weeks of EMD pulpotomy. So next material is propolis. It is a wax cum resin substance that is produced by bees. It has shown to have an antibacterial, antiviral, antifungal, immunostimulation, hypotensive and cytostatic activity mainly due to the presence of flavonoids, aromatic acids and esters. Carmen et al. Showed that 10% propolis tincture was as effective as formocrosol pulpotomy in primary molars. So coming on to the non-vital pulpotomy, it is also known as mortal pulpotomy. Ideally, these teeth should be treated by pulpectomy, but pulpotomy is done because of lack of patient cooperation. So basically the indication is inability to arrest hemorrhage from the amputated pulp stumps during a single visit, non-vital coronal or a radicular pulp, or pulp without the presence of abscess. So basically all the indications are of pulpectomy except for pulp without the presence of an abscess. So in first appointment, the procedure is almost the same. The medicament is left in the pulp chamber for 7 to 10 days as we do in the usual pulpotomy. And in the second appointment, non-vital tooth should be symptom free. So in the second appointment, we have to evaluate the patient clinically, and the pulp chamber is filled with ZOE after the patient is symptom free. So if the symptoms persist or an abscess or fistula develops, then a pulpectomy should be performed in that case. So basically, only we have to look for one thing, that there should be absence of abscess or fistula after the first appointment. So triantibiotic paste is generally used as a pulpotomy agent in such cases. So triantibiotic paste has been documented to be used in the vital pulp therapies as well. It is a combination of metronidazole, ciprofloxacin and minocycline. This concept is better known as LSTR and was developed at the Cardiology Research Unit, School of Dentistry, Niigata University, Japan. This technique allows disinfection of the dentinal, pulpal or periradicular lesions using a combination of antibacterial drugs. So to conclude, success or failure of pulpotomy is dependent upon an accurate diagnosis at the time of treatment and the knowledge about the various pulpotomy medicaments, procedures, and a sound diagnosis will help a pediodontist to deliver appropriate pulp therapy. So these are the references. Thank you.